Now, in 2023, measles killed over 100,000 people worldwide. 100,000. That's a disease we have a vaccine for, a disease that was on the verge of global elimination less than 15 years ago. It's back. And the reason it's back has very little to do with the virus and everything to do with us, with you and I. Vaccination is one of the most successful medical interventions in human history. It eradicated smallpox. It has almost eliminated polio. It saved an estimated 150 million lives in the last 50 years. And yet, in 2026, we're seeing outbreaks of diseases that should no longer exist in places that had eliminated them, in children who had no reason to get sick. Here in South Africa, we have our own complicated relationship with vaccines, a primary healthcare system that has achieved remarkable immunization coverage in some areas and devastating gaps in others. A post-COVID trust deficit that is real, measurable, and hear me when I say this, dangerous. And communities where misinformation goes viral faster than any virus. Welcome to Health Matters, where the science of human flourishing meets the reality of everyday life. Your body is the most extraordinary thing you will ever live in, and it was built to thrive. But somewhere between the noise, the busyness, and the bad advice, most of us never got the owner's manual. I'm Dr. Michael Mole, and that's what this show is all about, real science made human. Today, I want to do two things. I want to tell you what vaccines actually do, and in plain language without the jargon. And I want to look honestly at why so many people here and globally are choosing not to vaccinate, and what the science says about how we change that. So joining me to help me share this with you is Professor Hannelie, one of South Africa's leading authorities in vaccine science and immunology, whose research sits at the intersection of infectious disease, public health policy, and community immunity. I've got to say that slowly. Community immunity. Her work is exactly what this conversation needs because it's rigorous, it's honest, and it's deeply human. Professor Hannelie, welcome to Health Matters. So appreciate your time.
Thank you. Thank you very much for having me on the show today. And I really enjoy talking about vaccines because, as you said, they save lives, which is the most important thing that we are aiming for.
And I'm glad you started with that because that is the message we want to get through today. Now, there's a lot to unpack and lots of untruths that need to be put to bed, especially untruths. So let's start with the fundamentals before we get into that, Prof. For someone who has never really understood how vaccines work, can you explain what's actually happening in our bodies when we give a vaccine? What does our immune system do with it?
Yes, very important. So let's start by understanding how we respond to infections. So a pathogen is a tiny organism, commonly referred to by us as germs, that causes disease. So when you get an infection that you have never been vaccinated against, your immune system responds by making antibodies or killer cells that target specific proteins we refer to as antigens belonging to that germ, causing the infection, and then destroy the pathogens or the germs. Now, it can take a few weeks for your immune system to actually clear the infection. And while this is happening, you may become very ill or may even have lifelong complications or die, depending on the disease. So after recovery, your immune system retains memory cells so that they actually get woken up if you are exposed to the same antigen of the pathogen again in future. Now, because this immune memory, your body can either avert the infection completely or you may get a much milder illness again, depending on the disease. So, for example, if you fully recovered from measles, as you mentioned, a big problem, you would have lifelong immunity. But if you fully recovered from something like chickenpox, you may get mild chickenpox in the future. Now, vaccines basically work on the same principles, and they are based on the antigens of the pathogens. So they work exactly in the same way, but instead of having to get very sick while your body mounts that immune response, all you feel are the effects of your immune system being kick-started for a day or two. For example, this tenderness, swelling and redness around the injection site, or perhaps a headache or muscle aches. So this shows actually that the inflammatory response is kicked in and triggered a full-blown immune response that will result in immune memory, which you will need in future when you get into contact with those pathogens.
Brilliant. And Prof, I think I so often hear people saying, I took the vaccine and then I got sick. You didn't get sick. It's as you described, your immune system is just kicking in, and that's that head cold that you feel for that day or two. But you're getting the most unbelievable immunity at no cost, virtually. So thank you for explaining that. The concept of herd immunity, all right, gets used a lot and misused even more. Can you explain what population level immunity actually means and why it matters even for people who are already vaccinated? I'm vaccinated against measles and came close to getting it just the other day. So would you explain that to us, please, Prof? Herd immunity.
Yes, very important again. So in simple terms, population immunity or herd immunity occurs when all susceptible people are surrounded only by immune people and never encounter an infected person. So susceptible people include those who are too young to be vaccinated, for example, babies, those who have been vaccinated but they have not been able to mount a good immune response, for example, those with compromised immune systems, and then also those who cannot be vaccinated. And that would be people who might have an allergic reaction to specific vaccines or their components, or those who cannot receive live vaccines because they have compromised immune systems. So herd immunity, we also refer to the herd immunity threshold, and that is the percentage of the population that must be vaccinated to surround every susceptible person with only immune people. And this differs actually for every vaccine. So it's not the same for all vaccines, based mainly on the effectiveness of the vaccine and the transmissibility of the pathogen. In other words, its ability to spread or how contagious it is. Now, and a good example is the measles virus. So the measles virus is highly contagious. It's a highly transmissible pathogen. And even although 2 doses of the measles vaccine is more than 90% effective, at least 95% of the population must be vaccinated to protect all susceptible people within the population.
And what happens when we drop below that threshold? I mean, we've seen this played in real time, and I'm glad you mentioned measles because there have been measles outbreaks in Cape Town. So
yes,
help us understand
yes,
the importance of I get vaccinated for my fellow man.
Yes, exactly. And I mean, we shouldn't be seeing measles, in this day and age anymore. But because the coverage in South Africa has been on the decline, which is exactly why we are experiencing these repeated measles outbreaks actually over the past 2 decades. Now, we need to keep in mind with measles that babies get their second dose of the measles vaccine only at 12 months of age. And we have a very high prevalence of HIV in the country. So 95% coverage is really essential to prevent these outbreaks. But we've also seen outbreaks of rubella, for example, because of the low measles rubella coverage in the country. We've seen outbreaks of diphtheria and pertussis because of the low hexavalent coverage, which prevents these as well as for other diseases. So yes, very important to have high coverage for all vaccines.
And we can get into the data later, but I do recall reading somewhere that we should be at 95%. I'm going back to measles now. We are around 83%, and in certain provinces, we're as low as 70%. So that really is a concern for us. But let's see if there's time afterwards to really dig into the weeds there. Different vaccines, Prof, use different technologies. So without going too deep into the biochemistry, can you briefly explain the main categories and why we have different types for different diseases?
Yes, yes, indeed. And that's also why people often think, as you mentioned earlier, that, I got the influenza vaccine and now I actually got influenza, and even with COVID-19. Now, just to try and explain it in a simple way, most of the vaccines we use today are based on purified antigens or toxoids, which are proteins that are not able to cause disease. So, these include vaccines like, for example, influenza, the one against cervical cancer, hepatitis B, diphtheria, pertussis, tetanus, polio, and so forth. But there are a few vaccines containing what we call live attenuated forms of the pathogen, with this attenuation process stripping the organism of its ability to cause disease. Now, these include, and as I said, it's only a few, the BCG vaccine that prevents against the worst forms of TB in infants, the oral polio vaccine that prevents polio in the first weeks of life through gut immunity, the rotavirus vaccine that prevents against severe diarrhea, and then the combined measles rubella vaccine. So but then also what happened during the COVID-19 pandemic, we've seen now a new technology where we had two types of COVID-19 vaccines in South Africa. And both of these were based on the ability of the host cell to manufacture foreign antigens and then build an immune response against these same antigens. So one was the mRNA vaccine, which is based on synthetically constructed mRNA, while the other one was a harmless, non-replicating adenovirus as a carrier or a vector to deliver the genetic material needed for, the body to build, an immune response towards this.
Prof, you mentioned new technology, but mRNA technology used in the COVID-19 vaccines sounded like it was new, but the platform itself has been in development for decades, almost 3 decades. I mean, it wasn't new at all. We just used it for COVID-19. Would you set the record straight on that?
Yes,
and again,
yes,
it all goes
indeed.
to this vaccine hesitancy, because how can someone come up with a vaccine so quickly? It wasn't quick. It was 3 decades in the making.
Yes, exactly. And, that's a very common myth or idea that people actually had about the COVID-19 vaccines. But, firstly, there's a couple of reasons. Firstly, a lot was already known about the human coronavirus family before the COVID-19 pandemic. So some cause the common cold, while others cause severe acute respiratory syndrome, or SARS, that we've seen in around 2002, 2003, and then also MERS that we've seen in 2012. Now, secondly, from the start of the COVID-19 pandemic, there was a high level of global cooperation resulting in the early availability of the SARS-CoV-2 genetic sequences from around the world. And then thirdly, as you mentioned, this mRNA platform was already fully developed and available before the pandemic. And because this mRNA, as I said, is made synthetically, the vaccine could then very quickly be developed and clinically tested within less than a year, with some phases of the clinical trials actually being conducted simultaneously. And then finally, all of this was made possible through massive global funding. Now, to put this into perspective, in contrast, traditional vaccines, as you mentioned, they often get invented by scientists working within universities, who must then try to get funding for further development. Now, this can take years to happen. And once they have secured funding, the vaccine must first be grown, then purified, formulated, and only then get subjected to the 3 phases of clinical trials. And then also you need to have the results of each of these phases before you can move to the next phase of the clinical trial. And this process can take more than a decade.
Yeah. I think what I'm hearing you say, Prof, and this is what we've been trying to share and have been since COVID-19, is we didn't skip steps. We didn't take shortcuts. We weren't risking people's lives. This has been technology that's been around a long time. We just used it on a global scale, which is great. So thank you for sharing a bit about the technology on vaccines. I've got a listener's question that leads into our next question. I live in a township in Gauteng, and the clinic near us is always out of vaccines for my baby. That's horrible. Always out of vaccines. But I see on the news that South Africa has a national immunization program. What's actually going on? Thank you for that question. South Africa's got an expanded program on immunization, EPI we call it, which is meant to provide free vaccines to all children from birth. So how, Prof, would you describe the current state of that program? What's working? What's not? Where are the critical gaps? Tell us a bit more about EPI.
Yes, indeed, we have really a very good expanded program, or EPI, as a national program. But in reality, the program is run by the different provinces. So, like the listener mentioned, these provinces are given sufficient funds to support the EPI from the National Treasury. But it's clear that these funds are not always used for the EPI in some provinces. And, we can see that, for example, essential posts are often, vacant at district or health facility levels. And there are often shortages of vaccines at health facility level, but there is no national shortage. So our research conducted actually prior to the COVID-19 pandemic has shown that these types of what we call health facility obstacles are the main barriers to achieving the EPI coverage goals in the South African public sector. Now, we also have best performing provinces and worst performing provinces. So between 2018 and 2023, those were actually Mpumalanga, with an average of 93% fully immunized under 1 year coverage. So we refer to FIC.
Well done, Mpumalanga.
And
very cool.
Yes, and 90, around 90% for the second dose of the measles vaccine. And then also KwaZulu-Natal was also performing very well, during those years, with an average of almost 92% FIC and 86% of the second dose of the measles vaccine. However, what we have seen now coming from after COVID, and now I'm talking about the very, very latest data. So it's not published data, but, from the EPI program. These two provinces, actually, they are not performing that well anymore. While the two best performing provinces were actually Gauteng and the Western Cape. However, neither of them was able to actually attain the optimal coverage for any vaccine, like we mentioned earlier on 95%, or at least 80% for fully immunized under 1 year coverage. So yes, there's definitely some disparity, across the country and across provinces.
So, Prof, as I'm hearing you, the COVID-19 pandemic didn't just create a new vaccine challenge. We're going to talk to that in a moment, but it also disrupted the existing vaccination infrastructure significantly. So how badly did child immunization take a hit? I mean, are we seeing downstream consequences? We talked about a measles outbreak. Is that because of this lack of vaccination?
Yeah, so it definitely had an influence, I would say, in the delivery of services. Because, a lot of services was directed, especially, human resources, in other places. Although on the other hand, the cold chain infrastructure was actually strengthened by the COVID-19 pandemic. So I referred to, fully immunized under 1 year coverage, or FIC, and measles second dose. So the coverage took a dive in 2020 and 2021 to just below 80% and 76% respectively. But then there was a remarkable recovery, actually after around 2021 and 22 to levels even exceeding pre-pandemic levels. So I'm talking about 85, almost 86% for measles, and then 84% for FIC. However, now, like I mentioned, now immunization coverage again has taken a dive again, and we are now beyond the COVID-19 pandemic to a low about 71% fully immunized under 1 year coverage now in 2025. And by the end of last year, the number of zero-dose children in South Africa, meaning a child at the age of 1 who hasn't received a single vaccine, has increased to almost 400,000, which is about 33% of the under 1 year population. And I mean, it shouldn't happen in our country where we have free vaccines available to all children. So that is unfortunately why we have seen all these vaccine preventable disease outbreaks. It's because of these immunity gaps in our population.
Well, Prof, we're going to get to that because I think that's the key of what I'd like to really talk to is why. Why are moms and dads, but moms in particular, the caregivers, not vaccinating their children? Is it these WhatsApp groups and social media that's really spreading fake news? It bothers me, but let's put a pin in that for a moment. I quickly want to talk about going beyond childhood vaccines, and let's quickly talk adult vaccination in South Africa. So you mentioned flu and HPV for adolescents, hepatitis B for healthcare workers. I've got 2 of them in my own family. Are we doing enough there?
So, when we talk about adult vaccination, we are not doing enough yet, but the National Department of Health is really working towards strengthening what we call now life course vaccination. In other words, vaccination for everybody from even before birth, up to elderly people. So just an example is last year, free HPV vaccination, which is to prevent against cervical cancer, was expanded to include private sector schoolgirls in grade 5. And currently, during the HPV vaccination campaigns, both boys and girls in grade 5 actually receive free boosters of the vaccine against tetanus, diphtheria, and pertussis. So while we are really falling short with adult vaccination, apart from the fact that we procure a limited number of flu vaccines annually, we procure around 1 million or 1.2 million flu vaccines for the country. The uptake is really low in South African adults. So unfortunately, we do not have coverage rates for something like flu vaccines, similar to what we have for the EPI. But I mean, we did a national survey in 2018 and amongst elderly people across the country. And we found that only 32% of the elderly received the flu vaccine. And then vaccination against things like shingles and pneumococcal disease was amongst the elderly was almost unheard of. So when it comes to healthcare workers, as for the flu and hepatitis B vaccination, we also, as I said, we don't have official statistics, but as an example, also we found that of healthcare workers caring for the elderly at that stage in 2018, less than 30% were fully vaccinated against hepatitis B, and only about 33% had received the flu vaccine in the previous season. So, if we look just at the flu vaccines distributed in the public sector on an annual basis, and we look at, for whom those vaccines are being used, I can tell you that for healthcare workers, it is less than 10%. So another factor is that we are also lagging with our vaccine offerings in South Africa. So although we have some vaccines being licensed by SAPRA for adults, they are either not available or they are not offered to adults in the public sector. So, for example, now the COVID-19 vaccine is not available at all. The RSV vaccine, which is a new vaccine, is available in the private sector, with future prospects or planning to offer it also to pregnant women in the public sector. And then the shingles vaccine that many people are actually talking about at the moment, it hasn't been available literally for a couple of years, although we are now expecting a new shingles vaccine, which will be available in the private sector around the second half of this year.
Sure. Prof, you are like a walking encyclopedia on vaccination. Thank you for that.
I wish.
And the data and the statistics, it's quite phenomenal. But let's not miss, with all the data, guys, let's not miss the message here. I mean, flu in an elderly individual is dangerous. It kills people. Yeah. So to have that vaccine, and the fact that we only have 1 million flu vaccines in the country, I think we could do way better than that. Prof, I've got a question for you from one of our listeners, and it takes us into the next stage of this particular conversation around myth busting. This one makes my skin crawl. Let me read it to you, and let me pose the question. But here's the question. I didn't vaccinate my daughter because a friend sent me a video saying vaccines cause autism. If you're that friend, shame on you. My doctor says that's not true. It absolutely isn't, but I see it everywhere online. Who am I supposed to believe? So let's deal with that biggest myth directly. I mean, the claim that vaccines cause autism. I know where that come from, but you tell us, where did it come from? What does the research actually show, and why does this myth persist despite overwhelming evidence against it? I hope you mentioned the Danish study, 650,000 participants showing there is no connection. But Prof, just blow this myth for me, please.
Yes, exactly. This is a myth, and it also makes me almost angry when I hear it's still going around. But it was created by a fraudulent publication in 1998. That's way back. On 12 children, only 12 children with autism who had received the MMR vaccine, and which was then falsely claimed that this vaccine caused autism. So while this article was subsequently retracted and the false claim, as you mentioned, thoroughly refuted by many, many subsequent studies on huge sample sizes, widespread media attention at that time resulted in continuous circulation that was later considerably amplified with the advent of social media. Because as I mentioned, this already started in 1998. Now, in addition to all the studies, as you've mentioned, on millions of children, which found no link between the vaccines and autism, last year the World Health Organization's Global Advisory Committee on Vaccine Safety conducted systematic review of 36 research articles, 31 primary research studies, and 5 meta-analyses published from January 2010 to August 2025. And again, no link between vaccines and autism spectrum disorder or any neurodevelopmental disease was found.
Yeah, I'm so glad you mentioned that. Dr. Wakefield, and in fact, it's not even a Dr. Wakefield anymore, his medical license was withdrawn. I mean, that's how bad it was. 12 patients. Please, if you see anything like that, definitely don't forward that on. And I think we're going to talk to WhatsApp in a moment because that's encrypted. We can't track that. It's this private engagement. Do not share any related videos on autism and vaccination. It is simply not true. Thank you for giving us more and more data to back that up, Prof. Vaccine hesitancy was actually declared one of the top 10 threats to global health by the World Health Organization, even before COVID, in fact. In the South African context specifically, what do you think the main drivers of hesitancy are? And are they different from other countries? Is it mistrust? I mean, what's getting people to not vaccinate? Why do we have so many children in this country and, in their first year who are not getting the measles vaccination?
Yes, so vaccine hesitancy has really become a huge problem now in South Africa. And there's a huge study currently embarked on in South Africa to determine, what is actually going on about vaccine hesitancy to be able to inform future strategies. But the problem is South Africa is a country with huge wealth and health disparities. So we cannot define drivers of vaccination behaviors that apply to all South Africans across the board. So in addition, vaccine hesitancy is context and vaccine specific. So you could be hesitant towards one vaccine, but not towards another vaccine. So we cannot define drivers that will necessarily apply to all South Africans and to all vaccines available in the country. So just to give you some examples again, our research on HPV vaccine uptake amongst women living with HIV identified lack of awareness as the main driver of extremely low HPV vaccine uptake. But in contrast, our research on caregivers of age-eligible girls attending private and public sector schools in South Africa found that safety concerns drove vaccine hesitancy, resulting in girls not being vaccinated. Another example is that we found health facility obstacles, which I actually mentioned earlier as well, to be the main drivers for missed infant vaccination amongst caregivers attending public healthcare facilities. And then also, interestingly, our social media research has shown that South Africans are highly influenced by mis- and disinformation originating from the United States, which is reflected in other South African research reports, and false claims about lack of vaccine safety as one of the major drivers of vaccine hesitancy.
Okay, so it's complex. I get that. There's not one single reason, but is there a way to deal with vaccine hesitancy? And everyone has that member of their family, extended member, whatever the case is, that is so anti. We have it in our own family. What's the most effective way to address vaccine hesitancy for whatever reason? Well, it's in fact not whatever reason, because I think we are addressing, delivery and, the fact that there isn't a shortage of vaccines in the country, but there is provincial. So let's put that to one side. Let's talk specifically about misinformation, Prof. How do we deal with that vaccine hesitancy? You've heard the wrong thing.
Yes.
Who do you trust?
So there are ways in which you can sort of address or almost prevent vaccine hesitancy, if I can call it or describe it as that. So if you look at what we can do in the clinic setting, so research has shown, especially reviews on communication interventions called motivational interviewing, which is a very empathetic, non-confrontational dialogue, which consistently outperform just providing information on vaccinations. Another study, a very big study.
Can I double click on that? I think you're so right, Prof. The whole idea of people need to be right is a powerful driver. So what you're saying is don't confront, don't point a finger, don't wag a finger in the face and say you're wrong. Rather just share information in a far more conducive way. I think that's key to just highlight. So don't have the argument. Don't say you're wrong. Just share what you know.
Yes, exactly. So I have a what I call a standard SOP or standard operating procedure. So the O in my standard operating procedure that I recommend, the O stands for open dialogue, which is exactly what you are saying. So it means that as healthcare professionals, we should not just dismiss a person's concerns, but rather show empathy through humble, asking, inquiring, and compassionate listening. We need to listen to people's concerns. And I also have to mention, when we communicate, as I said, many people are concerned about the safety of vaccines. So one of the key issues is we need to be honest and we need to be transparent when we explain this to people. Otherwise, you are going to lose trust and credibility. So if there has been any missteps, you need to acknowledge that. And you need to explain explicitly, what do we know? What remains uncertain? what investigations are still underway, and, what are the interim recommendations. So these things are really important, and then, to treat people with empathy, listen with empathy, and not just bombard them with facts or, accuse them, make them feel guilty because they haven't vaccinated.
Yeah, I take that to heart, Prof. That's me, man. There's nothing better for me than the science and the facts, and you can't argue with that, but it doesn't often help. That's being punched in the face or hit over the head with an encyclopedia, and I know that doesn't help. Social media and health misinformation have become inseparable on more than just vaccinations, just health in general. But how significant would you say is the online misinformation ecosystem in South Africa as a driver of hesitancy? And is it getting worse? I mean, you talked about 400,000 kids not being vaccinated. Do you think that's a social media, influenced statistic?
Yes. So I mean, you also mentioned vaccine hesitancy was declared as one of the top 10 threats to global health in 2019. But, in 2018, Professor Heidi Larson, very well-known global figure, also heading the Vaccine Confidence Project, she suggested then already that the viral spread of mis and disinformation was the biggest pandemic risk. And unfortunately, we saw her prediction actually come true during the COVID-19 pandemic, which was accompanied by a deadly, what we call infodemic, caused by this explosion of social media mis and disinformation. And a very interesting fact. And as I mentioned, South Africans are unfortunately being influenced a lot about, what in terms of social media, what's actually coming or spreading from the US. So during the pandemic, there was a study where they followed millions of people on social media, and they eventually reported that just 12 people, which they named the disinformation dozen, were responsible for creating the vast majority of vaccine disinformation that was spread throughout the globe by social media users. And one of the 12 people, unfortunately, Robert F. Kennedy Jr., who was appointed as the U.S. Secretary of Health and Human Services in 2025, has been systematically, I can almost say, dismantling the U.S. vaccination program, and it also has an influence on people in South Africa. So it is not.
I had no idea that he was one of the 12, Prof. That's quite worrying. So RFK was one of the 12.
Yeah, you can actually go and look for the Disinformation Dozen report, and you will see all the names of the 12 people that they have identified to be responsible. I think it was for almost like 64% of the mis and disinformation being spread on social media. And unfortunately, this has had an influence on the uptake of COVID-19 vaccines in South Africa. And now it's also, we've seen this spill over to all vaccines available in the country.
Yeah, well, I've just made a note to myself to send this podcast episode to RFK and make sure he listens to it and listens to it carefully. So I'll let you know what he says. Prof, thank you for dispelling the bulk of those myths. We're going to get into a little bit of the how-tos now, if you don't mind. I've got a question from a listener that says, my son is 6 weeks old. I've been told he needs his first vaccines now. What exactly is he getting? Is it safe to give so many at once? What side effects should I affect? So these are just very basic questions. Would love your take on that. I mean, how would you respond to that from a mom's perspective? I mean, our EPI schedule starts at birth, runs through to school age. Just what are the key vaccines at each stage? If you can quickly explain simply what disease it protects against and why the timing matters.
Yeah, so I mean, as I said, we have a very good program. So there are actually many vaccines. I don't know whether I'll be able to explain all of them, but the timing.
Maybe we'll put a link in the show notes.
Yes.
Yeah.
So the timing of vaccination is really very important. So vaccination against each specific disease must be received in time to protect children when they are at the age of highest risk of severe outcomes from that disease. So our program actually starts before birth, where pregnant women are given, the Tdap vaccine. They are given the influenza vaccine to protect not only them, but also the infant during the first couple of months where their immune systems are still not fully developed, to protect them against influenza, tetanus, diphtheria, and whooping cough, so that when they get exposed to it, they will at least have some immunity while they are now moving into the normal EPI schedule. So in the private sector, as I mentioned, the RSV vaccine is already available for pregnant women, and we hope to see it, soon in the public sector program as well. Now, with regards to the babies themselves, they are given at birth, they're given the BCG vaccine to protect against TB, and then also they're given the oral polio vaccine to protect them for the first, couple of weeks against polio. So when they're now 6 weeks old, they do get another dose of the OPV vaccine together with the hexavalent vaccine, which protects against also polio and another 5 diseases: diphtheria, tetanus, whooping cough, hepatitis B, and Haemophilus influenza type B infection, which causes severe pneumonia, meningitis, and invasive disease. They also receive the rotavirus vaccine to protect them against rotavirus disease, and then also the pneumococcal vaccine to protect them against pneumococcal diseases. So then at 10 weeks, they get the second dose of hexavalent, and at 14 weeks, they comply with what we call the primary series of hexavalent vaccine, as well as the second dose of the pneumococcal vaccine. Then, as I mentioned earlier on, at 6 months, they now get the measles rubella vaccine. First dose at 12 months, the second dose, but in between at 9 months, they complete the primary series of the pneumococcal vaccine. So although, these vaccines protect them, they provide lifelong protection against, many of these diseases, they do need boosters as well, which is why they get at 18 months a hexavalent booster. And then the Tdap boosters protecting against tetanus, diphtheria, and pertussis, they get them at 6 years and at 12 years again. And then, for pregnant women, they get them during pregnancy as well. And for any other adult, you actually need boosters of especially tetanus to protect you throughout life. Now, finally, apart from being infants, girls in grade 5 at the age of 9 years, they receive 1 dose of the HPV vaccine, which prevents cervical cancer later in life. Because HPV is a sexually transmitted virus, it is important to vaccinate girls at that age before they become sexually active. And also because they then, at that age, they actually mount a very good immune response to the HPV vaccine. So that is in short, but we do have a very comprehensive schedule available within the EPI program.
Brilliant. Prof, thank you for going through that. What happens to a child who misses vaccines on schedule because of an illness or supply disruptions we talked about earlier, or heaven forbid, parental hesitancy? If a parent is listening to this and kind of going, wow, I am behind, what do I do? Is there a catch-up window? How does late vaccination compare to on-schedule vaccination in terms of protection?
This is actually a very important question, because people, once they realize they missed vaccination for their children, they actually become almost scared to now go and find out and, to try and get some catch-up vaccines. But please, it's never, never, ever too late to vaccinate, except for the rotavirus vaccine, which is only given up to the age of 24 weeks, and the BCG vaccine up to the age of 10 years. And then with regards to the hepatitis vaccine, if the mother at birth tests positive for hepatitis B, the vaccine, the infant will get the hepatitis B vaccine, and it must happen within 24 hours. So I want to stress again that, we have a schedule, but there's also a catch-up schedule. So people should go to these primary healthcare facilities with the child's Road to Health booklet, and then depending on, what's available in the booklet, or if they don't even have a booklet, depending on, they will ask the questions to the caregiver, and depending on recall of what the child had, they will then plan a catch-up schedule so that, the child can benefit most from all the vaccines that they still are able to get.
Brilliant, Prof. Thank you. Just to reiterate what you said, never too late to get vaccinated. No judgment. If you haven't vaccinated, go to your clinic, go to your pharmacist. Just go and get it done. Ask. There will be no judgment. To honor a listener's question, Prof, a quick one, and I think we can answer this. You've answered it in part already, but he says, I took the COVID vaccine under pressure from work. I think a lot of people did. Now I keep reading things online saying it damaged people's hearts or immune systems. I'm genuinely scared. Should I be worried? I mean, the COVID-19 vaccines were developed and deployed at unprecedented speed, given the global kind of get-together that we experienced. That speed, combined with mandates, political pressure, intense online debate, really created a perfect environment for mistrust. So where does the evidence actually land on the safety and effectiveness of the COVID vaccines in a nutshell? If you can, on a post-it note, Prof, give it to us.
Yes. So, there's a lot of data available that's shown that the COVID-19 vaccines are really very safe and highly effective at preventing severe illness and death. That was the main aim. So a modeling study conducted by the Imperial College London's MRC Centre for Global Infectious Diseases, they estimated that COVID-19 vaccines saved 19.8 million lives in the first year that it was used. So we need to look at this in perspective. Indeed, there have been very rare adverse events following immunization with both of the vaccines. Also in South Africa, where we vaccinated almost 40 million, or we used almost 40 million doses during the pandemic. But, I don't know if I should talk about it now, but I want to mention that the risk-benefit analysis or interpretation is one of the most difficult things for people, the public out there, to actually do. And that's why it's very important in terms of how we explain to people, and that we are very honest in our communication about the real rare events, but then also about the benefits of the vaccine.
Yeah. And to do it with gentleness and respect. Michael, that's for you. Prof, last question from our listeners. I'm a healthy 35-year-old. I had COVID twice, mildly both times. Do I really need a COVID booster? And while we're at it, what vaccine should adults like me, 35, actually be getting in South Africa? I think that's a great question. For a healthy South African adult who wants to know exactly which vaccines they should have and when, what does the evidence-based answer actually look like? And please make comment on that COVID booster as well, Prof.
Yes. So like I mentioned, in our country, we don't have COVID-19 vaccines available. Even if you do want one, we should be getting COVID-19 vaccines. Like elsewhere in the world, they are still using the COVID-19 vaccines, but we don't have them available in South Africa. So when you're a healthy 35-year-old person, it also depends on you mentioned healthy, but are you living with HIV? If you do, you do need definitely the influenza vaccine. So that is, one of the recommended or targeted groups for the influenza vaccine. It also depends on whether you are a healthcare worker. If you are a healthcare worker, you do need the hepatitis B vaccine together with the influenza vaccine, and also depends on where you work. Say you work in a laboratory and you are exposed to certain microorganisms, then you also need specific vaccines against those. And then, as I mentioned earlier on, we all need to make sure that we are protected against tetanus every 5 years. I mean, you can get an injury, and it's very important that you are protected against that. Another one is if you're a veterinary a vet, then you work with animals, so then it's very important for you to be protected against rabies. If you are pregnant, again, you need to get the RSV vaccine and, again, the influenza vaccine. So it all depends on your personal status. But, I could talk about the elderly and immunocompromised. There are, vaccines like the pneumococcal vaccine, the influenza vaccine, the RSV vaccine, the shingles vaccine. Those are really necessary for elderly people and people with immunocompromised systems to get those vaccines.
Sure. And to our listeners, hey, we're going to put all of that in the show notes. So there's been a lot of information that we've shared today. It's been a long episode, but a good one, full of data, full of insights. Final question for you, Prof. If you had 30 seconds with every South African listener right now, the hesitant parent, the young adult who skipped his COVID vaccine, the person who's been sharing anti-vax content without quite believing, but feeling a little uncertain, what's the one thing you would want them to hear?
I think I need more than 30 seconds, but, these are real concerns. Okay. So because there's so much credible sounding mis or disinformation out there, it's really difficult for people to discern from the truth, especially when, fake news, the source of fake news is someone you look up to, or even a healthcare professional. And this kind of disinformation can even be used as a political weapon. And what we need to remember is that these people who are spreading the disinformation, misinformation, they often have other agendas, to benefit financially from distributing the information. Important is to know that over the last 50 years, about, say, between 1974 and 2023, 150 million lives were saved by routine vaccination against 14 diseases, which is what I started with, and that's why I'm passionate about it, because we want to save lives. So there are 6 lives being saved every minute as we speak here today. So what we need to get into perspective is, yes, vaccines do cause side effects like any other medicine on the market. Serious side effects are extremely rare, and the benefits of vaccination far outweigh the risks. So please think carefully before you share anti-vax content. You may be supporting a charlatan while being responsible for preventable diseases and deaths in other people. And then lastly, if you have uncertainties, if you have questions, speak to a healthcare professional that you can trust, who will be able to listen to you and respond to your concerns based on scientific evidence.
Yeah. Prof, thank you. And I'm glad you ended with that particular line, scientific evidence, because of all your insights, of all you shared with us, the science is on your side. It's on our side. And so we need to listen to that. Thank you so much, Prof. So where does that leave us? For those of us listening, vaccines, as you heard our professor say, are not perfect. Nothing in medicine is perfect. There are real side effects, real risks, and real questions worth asking. What the science is unambiguous about is this: the risk of not vaccinating is almost always far greater than the risk of vaccinating. The diseases that we're preventing are not mild. They kill, they disable, they damage kidneys and brains and hearts in children who never got a choice in the matter. So if you have a child who's behind on their vaccines, the Road to Health booklet is your starting point. Take it to your nearest clinic. As I said, there's no judgment. There's a catch-up schedule. It is free and it works. If you're an adult who hasn't thought about vaccines since childhood, you probably need more than you think. Ask your pharmacist, ask your clinic. At minimum, an annual flu vaccine. a COVID update if you can. No, we can't. It's not in our country. But just check if you're due for a tetanus booster. Just do something and get some insights. Ask if you've been sharing vaccine misinformation, not because you're malicious, but because you were genuinely scared and something you read felt true. Here's my ask. Pause before you share next. Ask, as our prof said, where the information comes from, who funded the study. Ask what the 30 other studies on the same topic found. Anecdote is not data. Story is not data. Science is data. So here are your 3 things to do this week. 1, find your child's Road to Health booklet and check their vaccine status. 2, ask your doctor or pharmacist which adult vaccines you might be missing, specifically flu and pneumococcal if you're over 65 and HPV if you're a woman under 45. And finally, if someone in your life is vaccine hesitant, share this episode, not to win an argument, but to open a door. I know I'm going to be sharing it with RFK. I'm Dr. Michael Mole. This was another episode of Health Matters, because it does and because you matter. And Prof, thank you so much for your time once again.